If you live your life in the ivory tower, and I have been in academic medicine now for 36 years, I never have practiced outside the ivory tower. I understand that in terms of my authenticity, it's sometimes a question, well, this guy never has a lived experience of the topic for which he speaks. So I wanted to show you that in 36 years of psychiatry, I have lost 4 patients to suicide, and I've been named as an expert so far in 36 malpractice cases. 4 of them involve suicide. So it's from that perspective, along with some research that I've been doing on the topic of suicide, that I'm coming to you today. I want to say, and we'll go back just a little bit to the title, we have 2 objectives tonight. One is to talk about how to handle your patient's problems when you're immediately faced with suicide risk. And the second thing is how to protect yourself, because you're an equal party to this transaction. And I wouldn't say I'm the best psychiatrist in the world, but I feel like I do pretty well. And my feeling about the suicides I've had in my practice are, if you practice long enough, it's going to happen, period. And when I'm dealing with a trainee, and I've been working with residents and medical students for 36 years, when I deal with a trainee that's had a suicide in their practice and they are distraught about it, what I tell them is this, because I feel like somehow a suicide death is held to a different standard. I tell them that if you're an oncologist and you're the best oncologist in the world, some of your patients are going to die of what? Cancer. If you are the best cardiologist in the world, some of your patients will die of heart disease. And if you're the best psychiatrist in the world, some of your patients will die of suicide. So there's this tension between taking it seriously, having regret for the outcome, but finding a way not to beat yourself up on it, and also to protect your credentials and your reputation. So we'll be talking about all of that. All right. So our objectives will be to talk about recognizing the risk factors. I know as doctors we don't love to talk about epidemiological facts, but they will be relevant and important for this talk. We'll be able to describe specific treatments and approaches that seem to reduce suicidal behavior, albeit none of them FDA approved. And then in terms of self-protection, how to describe documentation and risk management approaches to risk mitigation. There are a lot of things in medicine which, despite seemingly fundamentally biological, follow sociological trends. And so things like an obesity epidemic has medical consequences. The obesity epidemic itself may be a sociological phenomenon that can be explained on the basis of poverty or food deserts or what people eat or the lack of exercise. There are a lot of factors that explain that, but ultimately has a biological outcome. And we see the same thing in psychiatry. There are several things here. By the way, these are the number of deaths per 100,000 Americans by year. And so the first thing is just to notice it's gone from about 10 to 14, a 40% increase in the span of 18 years, which is remarkable in and of itself. Do I feel like there is a biological factor that explains this? I do not. It's not to say that biology doesn't play some part in why people kill themselves. We'll talk a little bit about those, but that's not the only part of the story. So there are sociological factors as well. Brent and I were talking in the car about some of the trends with social media, and I'm not going to dwell on that too much, but if this group wants to go during the Q&A to talk about that, I'm happy to discuss it and how that may or may not play a role here. Another fascinating thing, just to kind of push home the idea that there are sociological factors, is what happened here. What happened in 2020? What's happening? COVID-19. And rather than this precipitate suicides, there actually was a temporary, you can see why I say temporary, reduction during the pandemic. Did you know the same thing was observed in World War II? Yes, sir. And it seems that when it really hits the fan, so to speak, and Americans need to rise to the occasion, when it's like critical, we can do that to some extent. And you'll see suicide rates decline for a while, and then they revert. So there are multiple sort of sociological trends going on here, but this is very, very alarming that it's gotten this high. If you look at mortality around the world, the Gates Foundation, Bill and Melinda Gates Foundation, poured a whole lot of money about 20 years ago into doing simple things to reduce mortality around the world, including treating dysentery, making sure people had access to clean water, that people got vaccinated for just simple things that kill you. Just very simple things. And they then repeated some epidemiologic world studies looking at death rates as a result of their actions that they took on behalf of humanity. And death rates from virtually everything around, every disease around the world went down between like 2010 and 2020, except one thing. What was that? Suicide went up globally. Well, how does Kentucky fare in all of this? The darker the color, the worse. We've got 5 grades of color here. Here we are in the middle, kind of stage 3, so it goes white, or this very light yellow is low risk, then it goes to this kind of darker yellow, and then to this orangey thing, Kentucky here. And there's going to be overlap, as we'll see in just a little bit, between the degree of rural life versus urban life, and explaining some of these death rates that we see. But Kentucky, it's a significant problem too, so we have every right in this room to be concerned about suicide death rates. You'll see, and this will make sense later, here's Montana and Wyoming, which is like the worst of the worst. And then Alaska, as you probably know, that native peoples and have very high rates of alcoholism and suicide. This, I think, summarizes the principal conundrum of being a practicing physician or PA or NP or whatever is your clinical role. And that is suicidal ideation is extremely common. These are yearly rates. Of that, a quarter of them actually make a plan for suicide. Of that, half of those attempt suicide, and I'm not disparaging this when I say, but only 48,000 die by suicide. So you are now in the clinic with someone that is expressing some degree of suicidal ideation to you, and you're wondering, is this person going to kill themselves in the very near future? And the statistics would tell you, if you just look at the raw numbers, the likelihood of going from here, 12.3 million to 48,000, it's an uncommon event. And this is one reason why, as practitioners, we're usually find ourselves in the position of, with some degree of ambivalence and anxiety, letting people go home. Because most do not commit suicide. And so how do you know, is there any way to say which ones really are at risk? Because that is the decision that you have to make. In terms of the importance of the topic, I'll just say one more thing about this. And again, I draw comparisons to provide context about how many Americans were casualties of our war in Vietnam. Vietnam lasted from what, 66 to 72, is that about right? Something like that. We lost about 53,000 soldiers. So we lose almost that many to suicide every year in the United States. Talking about the sociological factors. And this is important because if do we have any emergency room folks here tonight? So you're in the emergency room and you have 2 people who otherwise have identical stories that make you concerned for suicide risk, and one is white and one is black. Does that change your equation in thinking about this person's risk? Well, it should. And if we were to jump ahead to protecting ourselves against lawsuits, because even if we do the very best we can, people are going to die by suicide. To show thoughtfulness, you have to think about the totality of risk factors, some of which are population-based risk factors. Some are individual, but some are population-based. And so this is Alaska Natives. This is their rate. I guess this is per 100,000. These are non-Hispanic whites. And I'm just going to skip. I'm not going to read all these out to you, but here's non-Hispanic blacks. So it's about a third less than whites. Do I think that there is a purely biological factor that explains why whites kill themselves more often than blacks? I do not. It just doesn't make a bit of sense. And yet you would think with a variety of social deprivations and poverty and disadvantaging, you would think certainly black folk would kill themselves more frequently. That would be my first guess, right? That is not true. So what is there a potential protective factor for black folk? And one that I think goes back 100 years, 200 years, is that black culture, as best as I understand it, puts a lot of emphasis in terms of personal worth on things that are non-economic, including church membership, the power of the black church. That's where identity can be formed. That's not something we see, I don't think, in equal measure in the white church. That's my impression. So I think we need to look, because once we understand why there are these sociological differences, you can capitalize upon them as a society and try and reduce everybody's suicide risk. If we can understand why one group is advantaged and one is disadvantaged, then that potentially could be actionable. This has also been interesting. So if I'd showed you this slide from about 10 years ago, looking at suicide death rates by age, it would have been a straight line regressing like this. But now we see high suicide death rates in people 85 and older, and then it seems to decline, then it bumps back out again here, and this is new. This bump between people ages 25 to about 45, that's in the last 10 years. Again, is that biology? I don't think so. There's something happening to us as Americans which is causing hopelessness and distress, leading people to kill themselves. In the middle age groups, this was not seen as much a decade ago or so. What's that children's cancer hospital that Danny Thomas founded? St. Jude's. They do great work. Yeah, I'd say they do God's work at St. Jude's, but as a psychiatrist who's interested in this topic, what really gripes me is you would think that cancer is the most important threat facing the lives of children. It is not even close. But it is easier to give money to St. Jude's because we can't talk about these other things, right? We just can't talk about suicide. So this is the rank order list. This is 2022, all deaths with drilled down to ICD codes. I'm not going to read all this to you. By year. So when you're less than 1 year old, the number one killer is congenital anomalies. From age 1 to 44, the number one killer is accident. That shouldn't be surprising. And some of that's going to be little kids falling in pools and those sorts of accidents. Some, by the time you're 16, it's going to be motor vehicle accident. But here, let's look at suicide. Suicide is bopping around between the number 2 and the number 3 place between people 10 to 34. And here's the cancers down here. So suicide is like the second leading cause of death for your children and your grandchildren. Think about that. And think about where your heart goes and where you put your money. And I think this is my last piece of epidemiology. This is looking at death rates per 100,000 with men versus women. And I'm not sure it's because suicidal thoughts are that much more common in men as access to what? Guns. Right. So firearms are the most common method used in suicide death, and so this is the proportion, a little more than half of firearms. This is suffocation, meaning also hanging, and then poisoning Women, suicide attempts often take overdoses. And interestingly, we talk a lot about people cutting themselves. So where would that has to be here under others. So the likelihood of someone actually dying a suicide death by cutting yourself, as you might guess, is relatively uncommon. But guns is where the opportunity is. And men, I think there's lots of reasons why men are going to use guns more often than women. One is simply familiarity. It's what you know, right? And as a gun owner, it always shocks me that people don't even know how to open the breech to a gun. I mean, it's just so simple, right? And yet there are people that don't own guns and they don't have one at home. That lack of knowledge is enough to protect them. All you need to do is know how to use it and have it, and then you're at risk. So, can we make any guesses? Remember the state map was showing where the deaths were? We saw high rates of death in Wyoming and Montana. So these are rural areas, and we might think that there's a lot of gun violence in New York City, but the proportion of the people in Manhattan that actually have a gun in their apartment, I think it's going to be less than the number of long rifles and pistols on a farm in Wyoming. So we look at death rates, and this is year by year. You see it going up. This is for the entire United States. This is death rates in large metropolitan areas. So this would be like Atlanta. This would be medium metropolitan areas. I presently live in Winston-Salem, North Carolina, so this is where I would live. And this is rural. And so on a per capita basis, the deaths are happening in rural areas. And coming here today, I saw a lot of rural areas. And here's the mechanisms of death by location. So we've got, here's firearms, and this would be Atlanta, hangings, poisonings, and so forth. And if you look at these stay about the same as you go from large metropolitan to medium to rural. These look the same. What's jumping up? This line is jumping up, and that's firearms. So you put it all together, and you get a picture of access to firearms, ability to know how to use a firearm in a rural setting by men. And that's a high-risk group, especially white men. I have some vignettes at the end. We're going to talk about cases, malpractice cases I'm currently involved with. And we'll talk about the demographics, the age of the person, their race, access to firearms, and so forth. And I'll let y'all help me decide if you think these cases are high risk or low risk. These are cases that have not been heard in front of a judge yet. Just a little bit about biological factors. Low brain serotonin function has been repeatedly shown to be part of a suicide attempt. This has been shown in survivors of suicide who then went and had an LP done and looked at serotonin metabolites in their cerebrospinal fluid. Been done PET scans of the brain looking at serotonin ligands or the serotonin receptors, et cetera, et cetera, et cetera. So this is absolutely clear that serotonin's function is low, which that's at least something we think we know how to do about. High levels of stress hormones, the hypothalamus, pituitary, adrenal axis. This is one that I've been doing research on for a while, and I think these are actually related. It's the concept of hyperarousal, which is unfortunately vague. We need to kind of tighten this term. But the idea is people that are under extreme states of tension, they're highly reactive, they don't know how to self-soothe, are at risk for suicide. And as best as I can tell, this is from my own research and the work of others, it's related to this. Prefrontal, the medial prefrontal cortex of your brain right here is responsible for executive functioning and making decisions. So it turns out when you think about the release of noradrenaline through the autonomic nervous system, we think about the peripheral manifestations of the autonomic nervous system, but there's also an internal, central manifestation of the autonomic nervous system. And when your norepinephrine levels are running very high, and that is going into the medial prefrontal cortex, it in essence takes that part of the brain offline. You are no longer able to use your God-given ability to make good decisions when you're under a lot of stress and your medial prefrontal cortex kind of goes down. And so if I was going to tell a vignette story, it would go like this. If someone's medial prefrontal cortex was working well and they came in to work one day and they got fired, and then on the way home their wife or husband texted them and said, "I'm leaving you," and then you got home and found the dog dead in the yard, well, that person might say, "Well, this has been a terrible day, but here's my action plan. I'm going to have to do this and this and this to get my life back together." In other words, life has given them a brick wall, and yet they've been able, through their decision-making process, to work around the brick wall to a future. When you're in a state of hyperarousal and your medial prefrontal cortex goes offline, in that same scenario, your response is, "Well, I guess I'll just kill myself." So those are some of the biological factors behind suicide. And it's my only research from my lab I want to share with you. I've been doing work with pupillometry, which is to look at how the pupil responds to a light stimulus. So if I flash a light at your eyes, your pupil's going to constrict. And I can measure the velocity, the rate at which your pupil constricts, as an indicator of autonomic nervous system function. And negative numbers means the pupil is constricting faster. So these are just some patients, and I call them, have you ever been suicidal? You're either in the no category, the yes category. Increasingly negative numbers means more rapid constriction. And these are the people who have had a suicide attempt or who are suicidal today, and these are people who have never had a suicide attempt. And this can be done in the clinic. That's one of my visions for the future of psychiatry, is we finally have a lab test which you can do as a point of care test, like if you're an internal medicine doctor, you stick an oximeter on someone's finger, that changes your decision making before the patient leaves the clinic, right? Do we have anything in psychiatry where before you leave the clinic today, I can do anything to measure your biology and help figure out, is that going to move the needle at all towards suicide or not? And what I'd like to see one day is whether pupillometry, heart rate variability is another way to do that. Anyway, so these are some of the biological factors. So now let's get more clinical. We've talked about general risk factors, and the particular patient in front of you, you're concerned might be at risk for suicide, and you need to make some decisions. So the first step, we certainly can't do a full blowout psychiatric examination of every person. Even in psychiatry, we can't do a full psychiatric exam at every visit. So we need to have a stepwise algorithm towards risk assessment. And the first thing should be just what I'll call minimalistic screening for risk. And if that first step is positive, then you go to a more detailed. And I'm imagining a lot of this will be familiar to you. I'll get to that in just a second. So let's first talk about the other risk factors. So we talked about age, gender, race, chronic illness, prior suicide attempts is an unmodifiable risk factor. Psychological trauma, I intended to add one more thing here, which is important. I'll just tell you about very quickly, and that is proximity to the last clinic visit. Proximity to the last clinic visit. So irrespective of what discipline you're in, if a patient's going to commit suicide, there's a high likelihood that it will be within 45 days of the last time they were in a doctor's office. For whatever reason, they were in a doctor's office. A lot of suicide deaths were in contact with a provider within the previous 45 days. That doesn't mean we need to screen every single patient at every visit, but simply just to have some awareness that people will come into the office. We're talking about GI problems. People may come in saying, what I have is a GI problem, but behind that are other things going on too. So the extent of screening, I just don't know how much we should do, but simply be aware that proximity is very high. And to think about the ED, I forgot where my ED person was. So the first week after leaving the ED, very high risk period for suicide, period. And as far as psychiatry goes, being discharged from an inpatient psychiatry unit, even if the psychiatrist has thoroughly documented this patient is no longer suicidal, very high risk, and it actually is sharp. It goes very high for the first 3 days, the first 72 hours, declines some through the first week, and doesn't really become asymptotic till you're out about a month or more. That first few days, the first week's a very high period of risk. And you can't do a whole lot about it necessarily other than just document. Modifiable risk factors. Treating psychiatry problems is helpful. Alcohol and substance abuse. We were talking about the ability to make good decisions. This never really helps you make good decisions. Potentially, you could do something about shut-ins who are living alone. I mean, that would be a sociological intervention that might reduce the risk of suicide. I would talk more about access to means, especially firearms. Hopelessness, there are actually certain types of cognitive behavior therapy which are designed to reduce hopelessness. And then my area of research regarding suicide has had a lot to do with insomnia and nightmares. Just to jump ahead, I'll tell you this in my own practice. If I've had, a new patient were to come to me, outpatient, and I do a standard psychiatric interview. I'm going to ask them about their suicide history. Are they suicidal today? All those sorts of things. And then I see them 5 times, 6 times, 10 times. At this point, after 10 times, I feel like I know this patient. If you feel like you have rapport and you know this patient and they come in, do I ask them, are you suicidal today at every visit? Absolutely not. There comes a point where there's an assumption of a relationship and that maybe this person's going to tell me because they know I'm interested. I've asked before. But if the patient comes in for the 10th or the 11th visit and they say, Doc, I don't know what's going on, but I'm just not sleeping well. My sleep's been horrible. I can't fall asleep. I can't stay asleep. I'm exhausted during the daytime. I'm going to ask them, have you been feeling suicidal too? It's like the canary in the coal mine. If you suddenly have an eruption of sleep problems that were not there earlier, there's no harm in just asking, have you been thinking about suicide? I want to make sure I can help protect you to the best of my ability. So let's talk about the screening. So this is, I think, the most ubiquitous mental health screener in the United States, the Patient Health Questionnaire 9, PHQ-9. And there's also the PHQ-2, which is just the first 2 questions. And a lot of times what some health systems will do is they'll ask just the first 2 questions. If these are negative, then you don't even do the next 7. But if the first 2 indicate that depression might be present, then you ask the next. And the last question, number 9, hints at suicide, not necessarily in a direct way, but hints at it. And then if this is positive, that's the second stage, then you might do a fuller assessment of suicide risk. So we have to be smart about this, smart about it, and use our resources in a way that we don't go overboard with every patient every time. But I'm advocating for a stepped pathway. If the patient were to endorse some degree of suicidal ideation, then this is probably the best thing. I'm prejudicial, but I think this is the best thing to use. The Columbia Suicide Severity Rating Scale. And apart from Dr. Yao, has anybody else ever heard of this thing? One person. So I'll give you a hint about this scale. Our hospital had a Joint Commission evaluation. I want to say it was around 2015. And this was of a year that the Joint Commission was especially hot on suicide risk prevention. And they wanted to know, what were we doing to screen for suicide risk? And we said, well, every psychiatry chart, we talk about whether the patient's suicidal or not. And they said, yes, but are you all doing it the same way? Or are you allowed just to invent your own method? And everybody does it a different way that's not comparable. And they dinged us for that. They later came out with a statement saying there should be a systematic approach to suicide risk assessment. And you could choose any measure you wanted to use to do it. That's up to you. We're not going to tell you which rating scale to use, but pick something and have it done across the group. And then they said parenthetically, and we would think that the Columbia Suicide Severity Rating Scale is an example of what you might use. We thought, if you think that's an example, then that's what we're going to use. And so the Medical College of Georgia routinely uses the CSSRS as our final stage in doing suicide risk assessments. And another very cute thing about it, which would protect you, is that this is free, and there is free online training that takes about 30 to 40 minutes. And when you're done, it prints out a certificate. So if you lose a patient to suicide and you're on the stand, you say, I'm trained in the Columbia Suicide Rating Scale Risk Assessment. I performed it. But here are the critical 5 questions. The first question is passive suicidal ideation. Have you had thoughts you'd be better off dead or wish you could just go to sleep and not wake up? Yes or no? Have you had any just general thoughts like you thought, I think I could kill myself, but you haven't really thought about how you would do it. There's no intention or plan. It's sort of a vague idea. I think I could kill myself. If they say yes to that, then you need to keep going. So you keep going until you get a no answer. And then you get to number 3. Do you have a specific method in mind? I've thought that I could shoot myself. Then number 4 is, do you intend to do that? And number 5 is, do you have a plan, a place, a timing, specific setting? And the more granular it gets, the higher the risk is. And in general, is considered not necessarily an absolute emergency until you get to 4 and 5. If you were in a healthcare setting and a patient said, I intend to kill myself, number 4, or here's my plan for exactly how I'm going to do it, that patient has to go in the hospital. So this is really nice. It kind of takes some of the guesswork out of it. It allows you to objectify the severity. It allows a systematic approach that people can use in common. And is it perfect? Of course it's not perfect, but it's better than, as the Joint Commission would say, dealer's choice. Everybody doing it differently. Let's talk about risk mitigation. So now you've sort of come up with a sense of, is this patient at high risk or not, based upon their age, their gender, their race, their familiarity with firearms. Do they have terrible insomnia or not? There's a whole list of things you can kind of conjure together to get an overall sense of risk. So in general, the more people you can involve in the decision making, including the patient obviously, but loved ones, then this protects you. Observing the patient for enough time to convince a lawyer that you gather enough data. I'm going to give you an example later where I think that sort of fell through the cracks, that the patient was prematurely discharged. Safety planning. If your suicidal ideation gets worse, then these are the steps I would expect you to do to help yourself so I can help you. This all has to be in the chart. Limit access to lethal means. I can tell you that in Georgia, I don't know how bad the gun culture, and I said I have some weapons in my house. In Georgia, I would say, if you move to Georgia, you don't have a gun, we're going to issue you one. There was big time gun culture in Georgia. And trying to tell someone, we are going to take your firearms away from you whether you like it or not, how well does that go over? It's just not going to go over at all. So you have to find a way so that they arrive at that conclusion themselves and believe that it's their idea, if you can. And there's actually a way to do that we'll talk about shortly. And briefly, are there any specific medications or brain stimulations that will help reduce the risk of suicide? So we talked about if the patient's going to be discharged from your clinic or leave the emergency room or wherever they are at the time, and you feel like they do not have intent and they do not have a specific plan, and you're going to let them go. Remember, the vast majority, 1.3 million, think about suicide. Only 48,000 die by suicide. Most do not. No one's going to expect you to keep every patient for a long, long period of time. You have to pick the right ones and then justify it. So if they're going to leave the clinic or the emergency room, then they need to have specifically say, here's how you're going to get mental health care when you leave here, ideally with an appointment of some kind, to say they're going to go to X clinic on X or Y day. And if things were to get worse, we've told the patient to do X, Y, and Z, and these are their loved ones that are going to help surround them and protect them in the event things go badly. There are other psychosocial interventions which you cannot do at that time, but may be worth mentioning in a note for the future. Simply saying, I'm going to refer them to a psychologist for cognitive behavior therapy. I'm referring them to an addictionologist to help them get control over their alcohol and opiates. So this is a fairly obscure thing, but maybe your group will find this interesting later. There's some papers now. We wrote one of them at Medical College of Georgia on something called Lock to Live. You can Google it; it'll come right up. But it's a type of motivational interviewing. What is motivational interviewing? It's trying to, in a respectful way, get people who are stubborn off the dime and get them moving in the right direction, but getting them moving in the right direction because they want to and they've seen the light. So this is a structured interview which talks to people about weapons, people who are suicidal or potentially suicidal, and getting them to agree, you're right, I think I should lock these up, or I'm going to give these to my Uncle Joe, or have a plan, but it's not forced upon them. It is synthesized with the patient's input, okay? And again, is this perfect? No. But it's this sort of thing, if it were documented, would be great protection if things ever were to go in a direction you didn't like. And then medication. Maybe around the year 2000, there was some blowback against Prozac and related drugs, saying, oops, we think it actually makes suicide worse rather than better. I'm not sure anybody here remembers that bit of history. And now, so how is it shaken out as of 2024? The feeling is, overall, it's worthwhile to prescribe these, even to people who are suicidal. They should mitigate suicidal ideation, with one exception, and that's in very young persons, like young teenagers, early teenagers. You may need to be very cautious there. Psychiatrists, if you have a psychiatrist that can take care of people with bipolar disorder, that's a good thing. I think most major depression can be handled by primary care, or at least it should be, because there aren't enough psychiatrists to go around. Psychiatrists can't take care of every mental health problem. I think we should take on the worst stuff. We'll take on the worst stuff if we get help with other people just writing Prozac prescriptions when applicable. That would be great relief, and then we'll concentrate on the people with schizophrenia and bipolar disorder. But lithium has a universally agreed anti-suicide effect in bipolar patients. I don't know that we've come to a consensus whether giving lithium to, say, major depressive patients is anti-suicidal. But lithium is a good choice, at least in some situations, when you're trying to reduce suicidal risk. Clozapine, which is sort of like dropping the A-bomb on schizophrenia, and this is sort of the final place you go, has a clear anti-suicide effect. There was a study done by a guy named Herb Meltzer more than 10 years ago, and they randomized 960 patients either to olanzapine, Zyprexa, or to Clozaril. And they showed a clear reduction in suicidal behavior in those that got clozapine. So the feeling is clozapine is worth giving in patients with chronic psychotic disorders that you feel are especially high risk of suicide. Ketamine, intravenous especially, maybe not, the intranasal we don't know. Intravenous may have an acute anti-suicide effect that lasts for a few days. I don't know anybody that feels like it's a grand solution to suicide as a long-term problem. It's a very short-term. We talked earlier about having insomnia. is a risk factor for suicidal ideation. This is some work that we did doing a study that no one else ever would do. One of the, I'll try to get us out of here on time. One of the bizarre features of big pharma and psychotropic drugs is if you are bringing a new antidepressant to market, there's a good chance when you look at the inclusion and exclusion criteria that patients who are at suicide risk are uniformly excluded from the study. Now, there's a reason for this. Now, the reason is quite simple. Imagine you're now Pfizer or Abbott or whomever with your new drug, and you're taking your data from your phase 3 clinical trials, and people have been killing themselves in your studies. Whether it's placebo or drug doesn't even matter. But now you're going to try to get this drug approved by the FDA, so it's all about return on investment. So you will intentionally remove the patients at highest risk for suicide from the clinical trials to get drug approval. What that means then is for us, when you have a patient in front of you who you think is suicidal today and you want to put them on some kind of new drug, there's an excellent chance that we'll have no data on how it works in that population because they were excluded from the beginning. So we did a study which was the opposite. We were interested in whether treating insomnia with zolpidem, generic Ambien, would reduce suicidal ideation. If insomnia is a risk factor for suicide, well, then if you treat insomnia, does that mitigate suicidal ideation? So we randomized 103 patients with depression, insomnia, and suicidal ideation. You could not get into the study unless you were actively suicidal. This is not a study Big Pharma would ever touch in a million years. And the patients who were randomized to get Ambien at bedtime had greater decreases in suicidal ideation than those who got placebo. The implication is it's a proof of concept that intervening on insomnia may reduce suicide risk. It's by no means the final word on that topic. And then neurostimulation, electroconvulsive therapy has decades of data showing it has an anti-suicide effect, typically in the short run. If we have any students of history or literature here, a lot of times people will say, but Ernest Hemingway got ECT and killed himself. And that's true. But he killed himself a good while, a few weeks after the ECT was over. And the anti-suicide protective factor for ECT is probably measured in a few weeks. It's not measured in months or years. And then finally, intensive transcranial magnetic stimulation, which means you do it instead of once a day, several times a day, is starting to look like a way towards reducing suicidal ideation in depressed patients. All right, we're going to finish with more about how to protect yourself, because the time may come that you're going to wish that your medical record looked really, really tight. And so what would tight look like? Well, ideally, before the patient leaves your office, document the lack of plan or intent. Notice it did not say document lack of suicidal ideation, because then no one would ever go home, right? It's just too common. But specific words, the patient does not endorse plan or intent. Document the patient's interest in psychiatric treatment. That I discussed that you go to X clinic and they seem agreeable to that. It's also nice if the patient is otherwise forward-looking in their outlook. If the patient tells you something like, sometimes I think about killing myself, but we've got this family wedding next month and I'm really looking forward to that, you go, aha! They don't see themselves as dead in a month. They see themselves as alive in a month, going to this event. Document that, the forward-looking nature of their outlook. Involvement of families or friends. I like to say that secrets are lethal. If the patient insists, doctor, I'm thinking about killing myself, but you can't tell my wife, this is just something between you and me, that's not a good place to be. I want to bring as many soldiers as possible into the treatment plan, right? And document who's involved in the treatment plan. Document what the safety plan is, referral to resources, rapid follow-up's been arranged. They're not going to be seen in 3 months. They're going to be seen in 2 weeks, if possible. Sometimes you're wavering on should this patient be in the hospital or not, and they may not quite meet criteria for involuntary hospitalization. So they're talking this kind of vague language, like, I just don't know if I want to live or die. But do you have an intention to kill yourself? No, but I just don't like living. Or do you have a plan to? No, I just can't see going forward like this much anymore. You're thinking, ugh. They're not saying the magic words that will allow me to commit them, and yet I think they should be in the hospital. Well, the obvious thing is to offer voluntary hospitalization. They will very likely refuse, but you have offered it, and you document, I offered voluntary hospitalization. And then documenting this ASAP rather than days later. So then, the inevitable happens. You did the best job you could, and you have a suicide in your practice. So what do? The first thing is, do not alter anything you previously wrote. Of course, with electronic health records, anything that you do is going to be time-stamped, and that will be discoverable, and you have a problem. So whatever you did is what you did. Don't try to change it at this point. Could you write a new note after the patient's died to the effect of, I received notice from Mr. Jones' family that he died by gunshot by suicide 3 days ago. Can you put that in the chart? You could. And you could even, if there was more to the story to explain why he left your office, okay, but you just didn't put it in the chart, you can put that in now. Just don't alter what you previously wrote. You can write a new note which elaborates more of what you did in this patient's behalf. Post hoc, that's okay. But you don't want it to make like you're trying to fudge things. And then the steps after a suicide death. The first is if you have risk management for this health hospital, this health system, let them know right away. I can tell you, I'm married to a lawyer, have a child that's a lawyer. Lawyers in hospitals do not like surprises. They do not. Don't let them find out 2 months later when you're, receive a summons. They don't want to. They want to know about it now, and they will help you now. So never feel like this is something to be hidden. Maybe you will contact the decedent's family or loved ones, depending upon your relationship with them. Sometimes, and this is not by any means a rule, I've never done this. If you've been taking care of a patient for 20 years, is it okay to go to the funeral? It might be. I've seen residents who've had a suicide during training, and it can be just devastating. Like, oh my God, I feel I'm such a young doctor of the thinking, I'm such a new doctor, I really don't know anything, this is my fault, blah, 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 blah. And they're so ashamed, they don't want to talk to their attendings about it, which is a critical error. A lot of post-processing helps you make sense of something that seems to make no sense. But do not hide it and try to deal with it yourself. And so the final thoughts are: be aware of the common profile of the suicide victim, know how to move from gentle screening to a more detailed assessment, consider using the same instrument all the time, involve friends, family, other therapists, encouraging distancing from lethal means, consider looking at the Lock to Live instrument, which helps you do a motivational interview to get people to give their guns up, at least in the short term. If the patient is not committable, consider voluntary hospitalization, and if refused, then arrange for rapid referrals and safety planning, and document everything, especially if the patient has no specific plan and no intent. So that's more than you ever wanted to know. But I hope that was interesting. Thank you very much.